Hi, I'm Dr. Erica Elanan, and I'm here to present to you a webinar this evening on how to master the aesthetic zone with tri-dental implants. Put the money on it. So I'm going to tell you tonight why you should put your money on it. Great product, super advanced technologically, and so innovative. So I'm Dr. Erica Elanan, and my webinar this evening is on mastering the aesthetic zone and full arch growth. So how to build that practice and have it focused on full arch implant supported hybrid. So tonight we're going to discuss how to expand your implant practice, why tri-matrix implants are the best solution for not only single tooth replacement, but also full arch, and the advantage of using tri-matrix in the aesthetic zone with predictable soft tissue management. And I'm going to finish up this evening by going over quite a few of my clinical cases, from simple single tooth placement to some combination fixed restorative with implant placement, as well as some hybrid denture cases. So let's go on. And I'm going to tell you, first of all, just a little bit about my background and how I came into this. So I was originally a 6-year BA DDS student. So I graduated at 23 as one of the youngest in the country. And yes, I was young and dumb and thought, oh, let's just go out and open a scratch start practice. I had graduated with honors in cosmetic, orthodontic, and periodontal, and was published in Journal of Periodontology. So I thought I knew it all and would just open up a scratch start practice. You know, I probably should have waited a little bit, got some experience under my belt, but if I knew then what I know now, right? So luckily I sold that practice in 2008, right before the economic crash, and moved out to Anthem, Arizona, or to Phoenix, and practiced in Anthem for about 15 years. And then got the urge to open another scratch start practice, which I actually did, in fact, open about 3 years ago, called Smile Nouveau. But right before that, we had gotten hit with COVID. So while trying to open this current scratch start practice, every lease I had was just getting pulled left and right for emergency COVID units. And it just was not a fun process. Nobody was spending any money. We weren't allowed to practice dentistry, basically. And I'm like out in the middle of, kind of, what do I do here? I ended up going to a practice in Peoria, which had no hygiene department, shockingly. And all they did were overdentures, removable, and fixed restorative, as well as hybrid dentures. So, long story short, I was the dentist that swore I would never, ever, ever place an implant. And I'm sure Chris Luter remembers those days of me swearing up and down I'd never place an implant. I had better things to do, I said. And, now I have another scratch start practice, and that's all I primarily do is complex reconstruction, complex surgery, and full mouth implant reconstruction. I also practice in Scottsdale 2 days a week, doing exactly the same thing with it, Dr. Polis, who I've been with for a few years now. So moving on, I just want to talk about kind of how my skill set changed through the years from getting right out of school. And I'm sure a lot of dentists do, So, like I said, I never placed even an implant. And this was not until, maybe 5 years ago at this point. I went specifically from advertising and being known simply as a cosmetic dentist. I hate that name now. Where all I did were crowns, bridges, fillings, and veneers, and that's all I marketed to. We had the economic crash and COVID, where we weren't even allowed to practice fairly, or nobody had any money to spend on dental work. So I was primarily doing removable and extractions, and I was definitely still dabbling in full arch and doing a lot of full mouth reconstruction just because of, when the economy had crashed the first time, we had a bunch of holes to fill and a lot of cleanup work to do to put people back together. And then we got hit again with COVID. Until now, well, not recently, I'd say in the past like 10 years, I mean, primarily all I've done is complex surgical reconstruction, all types of complex extractions. There's not one extraction I turn away. I do place all my own implants now. I do all my own perio surgeries. And yes, primarily my practice is hybrid denture cases or fixed hybrid cases. So, with that being said, now is really the prime time to do implants because of COVID and because of the economic crash. There was just a ton of extractions going on, right? Because patients they didn't have the money or they were doing a lot of patchwork. And patchwork is just ticking time bombs. And all of these are areas that just are prime real estate right now for us to do implants. So it's really a good time to definitely focus on implants in your practice and grow it. So I want to talk about a little bit of how I used to market versus how I market now and what COVID and the financial crisis taught me, where, I used to focus just as a cosmetic dentist. Now I almost kind of feel like it's an insult to be called a cosmetic dentist. I feel like everything should be cosmetic. That's just a given. But what I noticed is during those times when patients were coming in really just in pain and they had a lot of emergency care, that's really where I should have been focused the whole time, because these were patients that, they didn't have a dentist. They didn't know where to go. They were very fear-based. They weren't very trusting, but they found the money to get themselves out of pain, and they weren't little filling appointments, that are low dollar. These are high dollar typically appointments, when we're doing extractions and grafts and pain management. And they always lead to either, an implant or a bridge or, finishing the smile off and making it look good with veneers and crowns. So I realized that I really should have been marketing for emergency dentistry way back then instead of cosmetic dentistry. I mean, back right after 2008, when I was in Anthem, I mean, there was 5 guys that went bankrupt. I mean, just advertising on cosmetic dentistry. So, your skill set either evolves with the economy and you're able to treat these patients, or you go under. So nowadays, all I really market to is emergency dentistry. I do market to the snap-in dentures, permanent dentures, smile design, straight dentures, and extractions. And the reason for that is a lot of patients that just want dentures, they don't know they want implants yet. And maybe they don't want them today, but they're going to want them later. They're going to want them the next year or the next year down the road when those plates aren't fitting so well, like we predicted and like we told them it wouldn't. So I try to cast a large net when it comes to emergency dentistry and that older demographic client, because a lot of times they don't really know what they need exactly. So let's talk just for a second about what that target consumer is. These are usually older patients. These are not your TikTokers or the patients going after whitening. Those are healthy mouths. They're not really interesting to me. I like the complicated jigsaw puzzle. I like the worst of the worst. I want the train wrecks, and those patients are usually extremely fearful of the dentist. They hate the dentist. They'll come in and tell you that, actually, like, just so you know, before we've even said hello, basically, I hate the dentist. It's like, okay, great. Well, we're already starting this appointment off fantastic. They're usually already in pain, so it's going to be a little bit difficult. Like, hey, I know you hate the dentist and all, and you're in pain, but I'm going to stab you like 50 times. And then I still want you to like me at the end of this appointment and trust me, right? And I promise I'm going to get you out of pain. Yeah. Difficult conversation. And they're usually used to that. They've already had like a history of traumatic dental, appointments in their past. They don't feel good about themselves. They know their mouth's a mess and a wreck, and they're usually physically really insecure. And as a result of that, they're usually just kind of depressed. They're not really that like upbeat, bubbly, excitable patient, so to speak. So it's really our job to help them like visualize that end goal and where they could be and who they could be. And they're usually very cost conscious because they're used to every time they go to the dentist to just costing them an arm and a leg or dumping money in, and the procedure's not working, and so they've lost a lot of faith, and they constantly are not really down with spending a bunch of money on their mouth because to them it's just like a waste. um so how do I address the whole cost thing? I mean, there's a lot of competition out there with these DSOs and the corporate dental model. They are offering just these really, really, really low prices. And for a scratch start practice, it is really hard to compete with that. And so I was seeing the pricing out there, and yeah, I this is an ad that I place currently. This is my main ad, okay, and it's showing that I do snap-in dentures for $39.95 and a hybrid for 15 grand, right? And I do the same for fixed restorative. And the way I was getting away with that is I thought I was pretty savvy with my shopping skills as female over here. And I was getting my implants for $15, and I was getting my multi units for $37. So that's pretty low. I even had set up a separate corporation as a lab, so that when I ordered my crowns or my implant crowns, I was getting lab to lab pricing instead of lab to dentist pricing. So when Chris came in and he's like, "I'll beat the price," I was like, "Yeah, good luck." Um, sure you will. My implants are $15, Chris. So good luck beating it. And he did, shockingly enough. Um, but with that being said, the one thing I'm not willing to ever compromise on is quality, and I've always held myself to a really, really high standard when it comes to the quality that I produce out there. And it's because to me, poor quality is an unhappy patient, and an unhappy patient is bad word of mouth. And that's negative Google reviews, and those will kill you these days. And it also leads to redos, which is lost chair time. That's money. And more lab costs, which that costs money too. And that will just kill a scratch start practice. So, traditionally, when I was coming into the market back 22 years ago, I interned with a really high end cosmetic dental lab, and their saying was always, "You got to pay to play, Erica. You want to play with the big boys, and you want to have these beautiful cases. Well, you're going to pay a top ceramist to get those results." And they're right. I mean, I still do to this day for my veneers. Yeah, I pay top dollar on my porcelain work. And it just traditionally, as quality goes up, the price goes up, right? And it's just remarkable that I've seen the quality that Tri produces with their PMMAs and their final fixed zirconia prosthesis, and it's beautiful, high quality work, and it is actually the lowest cost, which is just so opposite. It's the antithesis of the norm. So they definitely get away with that by not, having the multi units, and there's no abutments, and the digital workflow. I do not have a printer. Luckily, Tri is very sensitive to that, and so they have so many options to make it where that it's not just a do or die where you have to have a printer, because you don't. But the scanner, yeah, I started without a scanner, but it was kind of a necessary to put in practice before I started using try dental implants, but beautiful products. And I just wanted to let you guys know that, in with the Tri Matrix implants, you really are getting the highest quality for the lowest cost, shockingly. Um, so going back to like, how do I get these patients in the practice and build that full arch practice, right? Um, with that mindset of like they're depressed, they're cost conscious, they're the older demographic. These are your Facebook users, some of your Instagram users. I'm used to the yellow pages where I could do an ad and it ran for like all year in the yellow pages or in the newspaper and it ran for a week or a month or whatever. Now it's like, oh my gosh, I have to just create like crazy content every day. I can't have a day where I don't look good. Yeah, well, I got over that. Like, it doesn't matter what you look like. And I tell my staff that, like, I don't care what you look like. You just get in front of the camera. You just do it because, being genuine is more important to the patients. And them getting to be able to see that we have a personality. So that's why I say humor and approachability. Like, people are going to buy from you if they like you. We're still a sale. Dentistry is still a sale. Like, they can continue to let things rot out of their mouths, right? And they can continue to allow it to affect their overall health. But at the end of the day, we have to sell it to them. We have to make it a desire that they want and that they're going to be resourceful enough to get. And that, for me, comes down to educating these patients and, the way in which I kind of fight the whole like shame and them not feeling good about themselves is, instead of me harping on, how bad their situation is, I want to try to help them visualize and focus on the end game. Like, where are we going in their case? Well, what do we want them to be? What do they want to be? What do they want to see and gain from finally having the courage to address these problems they've had their whole life and doing it and fixing it, and how do they want to change to their life? But I'm always ready and willing to dial back that treatment plan. So if it really, really comes down to cost and they really don't have the funds or the way to finance, doing implants, I have no problem presenting, just removable dentures and allowing them to build that trust and save up. And once those plates don't fit, then they'll come back in because, we treated them right. And we rolled out the red carpet for them, regardless of what amount of money they were spending on their treatment plan. And we were just really empathetic and caring and loving and gave them the best quality we possibly could. And that made them happy in the moment, right? So I'm going to go through just a couple reels just to kind of show you the idea of first a humor one. So here's just one that's funny. And it's just, how do I get in their heads and make them feel like they meet us, know us, are part of our team, are already part of the office before they even come in, right? Because that's part of, building this patient demographic.
All right, bro. Looking good. We're done? Yeah, we're all done, man. What's up? Here you go. This is for you. You want me to eat this? Yeah, man. The candy. Yeah, sure. All right. That was a test, dude, which you failed.
So it's showing, yeah, we can have fun with it. And I don't expect patients to be perfect and do everything I say I'd love for them to, but that's not reality. And then here's one that's on education. So one of my patients sent me this video of the jaw sizer and wanted to know my thoughts on it. And when I saw this, I was like, oh, wow, why buy this product? I mean, you might as well just go to Petco or PetSmart and just go get a dog chew toy because it's essentially what this is. But when I saw it, I mean, yeah, great. Who doesn't want this beautiful, accentuated, angular face, right? Especially men. I mean, who doesn't want that square, developed jawline, right? Very angular. However, what this device would be teaching your jaw to do is to clench and grind. And a lot of my practice is treating really severe TMJ. So the last thing I want patients to do is hypertrophy or overdevelop those masseter muscles and cause a lot of TMJ pain that then I need to go in and treat with Botox or deprogrammers. Bad idea. So that's communicating to these patients. Like they think there's all these quick fixes out there on the social media, but the reality is it probably isn't going to work for them. Like nothing has over the years. So, this is education, but it's also, helping them come to terms with this is the reality. And we need to, take that step and actually go to the dentist. And then this is visualizing the dream, right? Like, where do we want to go with this? So this is a tri case and it's a combo case. So it's veneers mixed with implants. Shockingly, she's a young mom. I mean, it's just decay pretty rampant through her mouth, and her kids were only 2. She's Scottsdale patient. I was just kind of shocked at the extent of her mouth and where it was at, but so happy at the end of it. Put you on the A list to my nails. My hair, I'm a brand new bitch. To my nails, my hair, I'm a brand new bitch. My face, a glare, and my new look sick. I'm a place you can share. Put you on the A list to my nails. My hair, I'm a brand new bitch. So that's the beautiful part pointing out here with the tri implants is that because of their composition of the way they make this implant, it's a beautiful implant, whether you're placing it in the front or the back, it's aesthetic. So just to move on, I'm going to talk to you about why I chose tri. There's 2 different platforms, the P37 and the P45. The concave design, I'm going to talk about in a minute, but brilliant feature of the implant model here. They're talking about a reverse taper for subcrestal placement, which I'm also going to speak about here. And then moving on, talking about these implants with respect to hybrid cases with the angled screw channel. And that's what this little video here is going to show. So let's talk about this implant. The pink anodized implant collar is amazing. Not only is the pink color going to mimic your gingival tissue, it also, the anodized layer is going to aid osseointegration and actually improve osteoconductivity and better bone integration. It also is known to improve your biologic width. Okay. So the other part that's really amazing about this implant is the concavity here. And so initially I had a couple doctors say like, oh, well, could they make the pink anodized, could they make it white? And I was sitting there thinking like, well, why wouldn't you just place a bone level implant? Why would you make it white? Like I didn't get it here. I wasn't understanding the concept. And so I think that most dentists kind of go to that thought of, well, this is a tissue level, multi-level implant. So what if I accidentally place it too high, or if they don't have a ton of keratinized mucosa, and then the pink isn't so aesthetic anymore, and we start showing the pink. Well, I'm going to address that in a second here, but I do want to point out the concavity of this implant neck, and the beautiful part of that is it reduces crestal bone loss, and the reason why is it takes the pressure off the top of that crestal bone, and so it it just is amazing. And I've got a couple slides here that'll show you x-rays, which is right here. This is at placement. And this is at 3.5 years. And you can see that the bone just fills in beautifully around that concave uh, implant collar there. And that's mostly due to the pink anodized layer that's on there, as well as the shape of that implant collar. So in order to address the doctors that had, worried about potentially the pink collar showing, um, my theory was just sink the pink. Like, you don't need to use it as a tissue level implant. I mean, technically, you can sink it to crestal bone. And if you go slightly below it, just use a profiler. Trimatrix, they advocate that you should only be sinking the implant collar zero 0.5 millimeters below crestal bone height. And it's a 1.8 millimeter implant collar. So that would leave 1.3 millimeters potentially showing, depending on the amount of keratinized mucosa. I say just sink it. I mean, I that's how I do it for single units, whether I'm doing a single unit in the anterior or in the posterior. I expect all of my implant crowns to look aesthetic and picture perfect and, visually perfect. So I sink it. When I'm doing a hybrid or I'm doing a full arch, I leave the pink. That's just how I do it, because who wants to go fishing to try to find out where the platform is in order to drop your PMMAs or your final prosthesis? So I say leave the pink for hybrids and sink the pink for single units and for the implant bridges, anywhere that you think you potentially could show it. But this X-ray is just beautiful at proving the point, and I've seen it in my own practice. I have not seen any pink collars showing, but I do take a couple steps, and that's what I'm going to show you here. This is a single unit. I'm going to now show you some cases, and in these cases, I'm going to show you what do I do to make sure I have really thick, beautiful keratinized mucosa around single unit implants, and we'll go from there. So this is a traumatic case. It had external resorption, and this just shows atraumatic extraction. This is my drill depth burr, and you can see right here, I pretty much sunk this. Definitely went against what Tri recommends and sunk it further than the 0.5. It's just a beautiful implant to do it with, and I'm going to show you the results of this case. When I do sink it, or anytime I'm in the anterior zone, especially when a case like that's got external root resorption, you worry about bony defects. And so what I find to be the best at rebuilding all of that is using the allograft fibers, which are osteoinductive and conductive. So it's going to promote bone healing as well as bone growth, right? And then for capacity's sake, just to maintain that capacity and make sure that whatever volume I put in there, I'm going to also use that bovine xenograft. So I kind of almost sandwich it, so to speak. And then I take ADM, actually. So I've heard of a lot of docs, when they have thin keratinized tissue, going in and doing a CT graft, which is, to me, that's just a pain. It's just a pain in the butt. Like, I don't want to do another surgical site, and patient doesn't want another surgical site. So I've done a ton of research on this, and all the research is showing that ADM, which is acellular dermal membrane, it's almost equivalent to connective tissue grafts in being able to really beef up that keratinized mucosa around implants specifically. So I just use the envelope technique and slide it right up in there and suture it down around the either the healing cover screw or a healing abutment. So on this case, I used one of these handy dandy digital healing collars. So if you have a medic, you can design your own digital healing collar and place it at time of surgery and really design that emergence profile specific to the patient into the site. I don't have a 3D printer, remember? So what I did, you take it or leave it, is I just take a burr and then polish it up and just created that myself with burrs, polished it, screwed it in place, and then I placed my temporary right over that digital healing abutment. So that's just an alternative way to do it if you don't have a Medit or printer. And so this is her finish. These are just her temporaries. So I extracted number 10 that day, placed an immediate tri-matrix multi-level implant, and I countered and balanced it to correct that cant by doing 7 anterior veneer preparations with it. Then moving on, I'm going to show you another case. This is the little old lady who had lost her husband and was just a wreck and said she needed a reason to smile, and her husband would have wanted her to smile again. And she'd come into some insurance money, and so she was ready to go. She hated this pre-existing bridge that she had in place. As you can see, really pragmatic. She had a lot of wear. I don't have an open picture of this, and she was in posterior bite collapse over on the her left side. So after I pulled all the teeth, it's really important that you attach this impression transfer of the scan body before suturing. Then suture everything in place, and then you're going to place this handy dandy scan bridge that Tribe provides, which I will call everybody's attention to this, because depending on the height, you'll see some of these are short and some of these are tall. Okay. And there's different sized scan bridges, not just length, but also in the little clamp attachment. And so there's a trick here. If one just doesn't fit, because I didn't know, I've suggested, hey, let's make these kind of color coded so we know like short is one color, long is another color, so that they just snap in really easy. They just need to touch the other transfer or scan body, and then you're going to lute it in place with like a resin and like cure it before you scan. But these are brilliant. They pick up beautifully on the scan. And I'm going to show you that here.
Print and select the adequate scan bridge in length and angulation. Make sure to use a biocompatible and flexible material such as a crown resin. Brittle materials can lead to fractures of clipping mechanism. Next, attach the first scan bridge to the retention area of the 3D touch impression post, moving towards the neighboring.
So they don't all attach that easily.
Continue this process until all scan bodies are
dependent. They do, as long as you have the right size. So you can see there's a short one here and a long one here. But like I said, if it breaks, that's okay. You can still just kind of position it so that they're all touching here. And you're going to flow in this resin and just light cure it. So it doesn't really matter. They just all have to be one continuous arch here, and there needs to be space between where the scan bridge is and where the ridge or the tissue is. So this is just show basically my scan once I have it in place.
You need to get so hot when I get this.
So I'm going to bring this up because this is a little trick that I learned only after 5 labs in Scottsdale refused to do it. So I did get this PMMA and I wasn't thrilled, okay, because it looked a little irregular here in the edges. The incisal embrasures were not open enough for me. And the edges almost looked like they had mamelons or were a little chipped. So all I'm going to say is if you don't like it, change it. And I change it either with my finishing burrs, with the mosquitoes and composite. So I had 5 labs tell me you can't bond composite to PMMA. They're wrong. I did it. It lasted like 5 to 6 months on a patient. No problem. No chipping. no issues. And this is not the case from Fry, but this is a different case that they just absolutely hated the way the PMMA had come back from the lab. And she was getting married and was like, absolutely not. I'm not going to go get married the way this thing looks. And I was like, all right, well, no lab would make me a veneer overlay. So I said, I know it'll work. So I found a composite and did an overlay myself, and it was fine. So if there's ever something you don't like about it, change it. It's fine. This is a tri PMMA that I inserted. So on that lady that you just saw earlier that had lost her husband. So here's her. This is just her temporaries. And there was her upper hybrid, and I did 2 single unit tri-matrix multi-level tissue implants on the lower, but I also did 10 units of fixed restorative. So it was a little combo case there. So now we're getting into the nitty gritty, right? Like the train wreck cases. These are my favorites. I love the more complicated jigsaw puzzles, the better. So super depressed. It took me everything I could get just to get her to smile and show me, because I mean, she'd been so, upset. Her dad actually took her in. I think she had some previous drug history problems in the past. So yeah, pretty messy case. This is her finished case and her PMMA. Well, this is just her PMMA, but I want to impress upon everyone like how critical occlusion is. It really, just because you get the PMMA back and it screws in, we're not finished. We need to really make sure the bite is balanced. I call it full buccal, upper, lower lingual. Those are usually where the interferences are going to be, or especially when a PMMA comes back, it's either going to be a little heavy in the back. But we just want to make sure that that bite is balanced. So this is her with her PMMA in place.
Then down in the day when your brain goes numb, you can have them in the freeze when these people talk too much, but the shade is so ocean. Yeah, I feel like an astronaut in the ocean. What you know about rolling down in the deep.
I love to see them. They get so excited now they're like, oh, I'm finished with my teeth. I need like a neck lift, and I need my hair done, and they're moving on. So she did great. It was great to see her super happy. So this is her final result. I only did a denture up top actually on this case, because she didn't have the funds to do it, and since her dad was paying for it, so we because of Tri, so she only had the funds to do a snap-in. And I had mentioned earlier in this presentation that I really don't do snap-ins anymore. I'll present it just to see on the price point what's the patient going to go with. But Tri makes it so affordable that I just went ahead and did it for her, just to do a good deed here. And I think at the end of the day, it was cheaper for me to do this as a screw-in than it was for me to have a lab come in or chair side, convert a lower denture, and just way too many appointments with denture adjustments. So I was like, you know what, forget it. I'm just going to do it as a PMMA. And with Tri's implants, it makes it totally doable for me from even a startup practice perspective. So, and this is the last case. This is an upper lower hybrid. I had met this patient 5 years prior out of the Peoria practice, and he had tracked me down and was finally ready 5 years later. Sometimes these cases, they're going to develop over time, as long as you treat them right and help them visualize. Sometimes they just need to get some things in order. So this closed 5 years later, came in, and he's an upper lower hybrid. He did great. I mean, he's super happy, and I think tried an amazing, beautiful job. These are just his PMMAs. So these are just a few hybrid cases. This is a complex like reconstruction combo case, but these are also some hybrid cases with Tri. So I hope you guys enjoyed my presentation, and this is where you can contact me. if you have any questions or anything you wanted me to go over specifically. So I'm here.